Good evening all to the 66th session of the Weekly Huddle. I'm your host Anoop, and joining me today is my friend and co-host Praneeth. We are cardiologists working at Care Hospital, Banjara Hills. The Huddle, as you all know, is an unscripted audience level interaction where we address common clinical scenarios that we encounter in our daily practice. The basic premise of the Huddle is to bring our casual discussion into a more organized platform like this one and share our ideas. While we do want to talk about science and guidelines, with the Huddle, we intend to help a physician translate established knowledge to clinical practice, taking local factors and practice patterns into account, essentially a more pragmatic way of practicing medicine in India. This is not a speaker and audience model, rather a casual interaction, which means any of the attendees can raise their hand or unmute themselves to give their input. As a courtesy, you should wait for others to finish before you unmute yourself. As I said, today is our 66th session, and the case detail I have already shared on the WhatsApp group and on the invitation. I will detail the case right now, and I will ask my colleague Praneeth to give his first impression, and then we will ask our other attendees about their impression. So Praneeth, this is your case only. I'm just going to read it out so that the attendees get well versed with the details. And then you can tell us your impressions, and then you can tell us what did you do to this particular patient over the course of our discussion. So this is a 46-year-old male. We discussed this case about 2 weeks ago, if I remember correctly. This guy works as a commercial airline pilot, where he pilots the usual aircraft which carries humans rather than goods. And now he's joining into a new private carrier. So as a part of this new job screening, he has to undergo a mandatory health screening, which is dictated by the aviation guidelines in terms of what all he needs to do. In his routine evaluation, he was found to have right bundle branch block in the ECG, which he had previously as well. And as a part of protocol, because there is a right bundle branch block on the ECG, he was advised to undergo a treadmill test, which he flunked. He could not pass the treadmill test. It was reported positive. He went about 8 minutes on the treadmill, crossed stage 3 of bruise. He had 1 millimeter of ST depression in the lateral leads at peak exercise, which resolved within 2 minutes of rest. He did not have any chest pain at that time. His Duke treadmill score was noted to be +3. Because of this positive TMT, he was referred to a cardiologist for fitness to join as a commercial aviation pilot. This is when he saw you. This is when we were discussing about his details. He's otherwise a healthy 46-year-old male. He does not have any other medical condition. He is physically active. He is asymptomatic from the cardiac perspective. He is an active smoker, though. He has smoked a cumulative 25 pack years at his age. He does not have any family history of heart disease or sudden cardiac death. And he does not have any other conventional coronary artery risk factors, as you would put in, except things that we have already discussed, which would be his age, gender, ethnicity, smoking, and whatnot. He does tell us that 5 years ago, when he was joining another company, at that time also, an ECG was done, which showed right bundle branch block, which was followed by a treadmill, which was reported positive, and that was followed by an angiogram. And that angiogram, he says, was normal, although he does not have any report that he brought with him. The fact that he joined the airline industry and he was flying for the past 5 years, I'm guessing that his angiogram was indeed normal. So the discussion for today and this is something which is kind of offbeat for what we usually do in our practice. What is the basic fitness assessment one should do for pilots, understanding that most of these guidelines come from, or I believe it will come from, the aviation guideline directly rather than what me and you think. And I'm guessing for India, it will be a DGCA guideline that I hope they have published at some point. I have not read it. If somebody knows the DGCA guidelines currently, please share it with us. So that is the first question. What is the basic fitness assessment that you think pilots should undergo from the cardiac standpoint? how aggressive should ischemia workup be in these particular job profile patients? How should we interpret a positive TMT in asymptomatic pilots? Is the interpretation any different than what we would normally do for folks who are not in high-risk profession? And then what other job profile we should consider as so-called high risk, for whom the same standard should be applied as pilots in terms of the stringent criteria that pilots need to undergo for obvious reasons. Any other job profile where we should apply similar stringent criteria? So a lot of points to discuss. Praneeth, please walk us through what your thought process is. And then later on, I will invite you to also tell us what you ended up doing in this particular patient. Praneeth, for you.
Yeah. Good evening, everyone. So this patient came to me as mentioned. So when I looked at this patient, the first question is about fitness for his job as a pilot. Now coming to seeing him more as a patient, getting with the treadmill report. So whenever I look at treadmill, again, it comes back to what are the symptoms of the patient and what was the indication to do a treadmill for this patient. He apparently was asymptomatic. He did not have any symptoms and he did not have any risk factors other than smoking, which puts his pretest probability of having coronary artery disease as low. So to begin from there, the probability of having coronary artery disease based on treadmill also will be low. So, and the ECG changes did not look significant to me to suggest a possibility of having any ischemia. And now, having said that, now for clearing him for his job as a pilot is a responsibility, and equally because I will be liable to clear his job, I thought I could not leave at this point of time, considering the high risk profession, as I believe. So, and equally to satisfy the authorities at his end, that is where he was being referred to me. So few other investigations to answer this treadmill was considered. That is where I discussed, and I thought doing some other form of inducing ischemia was considered, and I ordered an exercise spec for him. Now coming to the questions of today's discussion on what is the regular way of giving clearance. The most important thing is about knowing at the risk factors and physical fitness and in the form of their specific activity, whether they are able to achieve 5 to 7 minutes in their day-to-day activities, and probably a basic ECG and echo are something which I do, and treadmill if I think as a part of ischemia evaluation, though I'm not very pro in doing treadmill because of its low sensitivity and specificity. The other question on guidelines of clearing them, I'm not aware of. The other high risk professions which may need aggressive intervention again are someone where not only his life but other people's life are at stake. Something like probably a crane operator or something like that, or someone like who operates other machinery where other people's lives are also at stake. That can't completely correlate, but maybe with a given situation I would try to look into it. So for him, I think there was some other investigations which were warranted, and that is how I approached this case.
A few questions I will ask you directly. So question number one, would you be comfortable going on an airplane if you know that that pilot has tested positive in a TMT, but cardiologist has cleared him with due course?
Maybe if I have seen him or I am the so-called cardiologist, I would be comfortable because I believe he has a low probability of having CID.
Well, yeah, but that probability is very low where you find a pilot with positive TMT who has been cleared by you and is flying your plane. the chances are that pilot must have been cleared by some other cardiologist whom you may or may not believe may have done a good job. I don't know. So
difficult question to answer, but I would take my chance. I would still get that flight. Take that flight, sorry.
Okay, second question, which I think is relevant not just in respect to pilot, but in respect to general cardiology that we practice. A patient who have got positive functional test like a TMT, but a normal anatomic test in terms of coronary angiogram or a CT or whatnot. In your consideration, do you think these patients are at higher risk of cardiac event rate?
So presence of a positive treadmill test in the form and having a major coronary arteries, epicardial coronary arteries being normal, can indicate a presence of an microvascular dysfunction, which also are one of the predictors of future ischemic events. But the issue is about probably in the form of having symptoms, angina or dyspnea is there, but in general, looking at their fitness in terms of threat, not clearing for job or something, I don't think I will consider, but maybe it explains his overall disease. In terms of having microvascular dysfunction, it can also have pain and dyspnea, and overall prognosis may not be as good as patients who are having normal TMT and normal coronary. So I will clear him for fitness if the coronaries are okay, even though his treadmill is positive.
Okay, Praneeth, hold on to your thoughts. I'll get back to you in terms of the follow-up of this patient. I believe this patient's follow-up is complete with you, so we'll get back to you on that. Sure. Srinivas sir, I hope you got the case details. If I can have your thoughts in terms of what you would do, just to brief you. 46 male asymptomatic, right bundle on ECG, positive TMT, normal angiogram 5 years ago. Clear or no clear to go as a pilot?
Yes, Dr. Anoop, I think most of the answers given by Dr. Praneeth are valid. He is fit to fly the flight. The thing is, it was positive only in stage 3. And definitely there are no other symptoms and he has no other risk factors. Probably it is just a false positive TMT. And considering that he is a smoker, probably we can just do a lipid profile, check the HSCRP. If the HSCRP is high or if the lipid profile is showing any abnormalities, we can put him on a high dose of statins. But if there is a remote possibility of a strong family history of coronary artery disease or TMT, which was showing ST depressions persisting into recovery, still doing a CT screening for calcium score would have been better thing to do, so that we are more sure, because he is going to there is going to be a chance of having the passengers at risk. Not only the persons who are flying a flight, even someone who is going to drive a bus or someone who is going to drive a train, probably the same can be applied to them as well, because they're all in public transport. And before saying definitely they could go ahead and take their job, I think it's definitely more correct to do definite evaluation, at least in terms of screening calcium scoring, before we clear them for their job. That's what I would do.
Thank you, Srinivas sir. So one thing that I will add, that is, airlines, they work in a very weird way. They are hyper vigilant about their air staff, so-called, getting incapacitated to do their job, because it's a big deal. So they have their own definitions, they have their own way. One of their definition is cardioactive drugs. I have no idea what that means, but one of their definition is cardioactive drug. And what that means is, and this again, I have to look into details. If somebody has the detail, please feel free to share. Any person who is on a cardioactive drug for prevention of cardiac event in the future, that person is unfit to fly. So if we do a lipid profile on this patient, or if we do HSCRP on this patient, if it is elevated and if we put him on a statin, my guess will be, and I really hoped I could get a so-called a medical officer who is expert at this in this forum, but I couldn't get it. To my understanding, if you put a statin on this patient, he's unfit to fly. He cannot fly after that. He has to be grounded. Same thing goes for hypertension management, and I believe few others, because their idea is the so-called cardioactive drugs. If a patient is on that, if a person is on that, then they are unfit to fly. And then I'm sure they have their own criteria in terms of what to do next, so that whether they are unfit to fly permanently, or whether they are unfit to fly maybe for a year or two and then get better. I don't know. But the answer, the way we approach these medical screening for pilots, unfortunately, are not the same as what we are going to do for our routine people here. So let me move on with our discussion. I will ask my attendees for their thought. Let's see, Dr. Shankar, I believe you have definitely seen at least a few of these kind of cases where you are so-called the medical officer clearing these high-risk profession for their fitness to resume their work. How do you look at it, positive TMT? Do you directly just refer to cardiologist and let them take the call, or you do something from your end? Shankar sir.
Good evening to all. An asymptomatic middle-aged man, smoker, and air crew, that's pilot, when exercise stress test is positive, then two things come to my mind. Whether it is a false positive, because in 5 to 12% of the men, this stress test may be false positive. It will be 20 to 30% even in women also. So here 5 to 12% false positivity there. And he is still asymptomatic patient. Still he may be harboring silent myocardial ischemia with occult chronic ischemic heart disease that may give a true positive. So this issue will be settled by the cardiologist only. I will refer it to tertiary care center. To patient should undergo stress thallium or technetium sesame B, that is a cardiolite gated SPECT scan, or a tetraformin, that is a MyoU gated scan, so that that will support if that myocardial perfusion imaging studies, they come negative, they come normal, then we can rule out coronary artery disease. That is my assumption, because he can be fit for be a pilot. But one thing we should remember, if we go through the literature, the risk of developing a cardiac event such as angina, myocardial infarction, or death in men is approximately 9 times greater when the test comes abnormal or the test comes positive than normal. During a 5-year follow-up study, generally 1 in 4 men will suffer a cardiac event. So this guy is at a high risk, because though he is asymptomatic now, but is a chronic smoker with other atherosclerotic risk factors. If they predispose to the accelerated atherosclerosis, he should be under strict surveillance. Every year he should undergo the TMT and calcium, coronary calcium score, if possible coronary CT angio, and the latest addition is a CT FFR. If the stenotic lesion is found in the CT angio, then we can assess the functional flow reserve. Also, that addition is there in the CT angio in the newer versions, newer generations. So these tests will be done to find out, because the atherosclerostic process is progressive.
And sir, one question to you, what I asked Praneeth as well. You board an airplane and you find out your pilot had TMT positive but has been cleared by cardiologist with due process. You feel okay?
Okay, because these studies I told now, the myocardial perfusion imaging studies are normal. Then coronary calcium score is below 100, and the CT angio and the CT FFR are normal. Then I do go with him. We do actually most of the times we don't know the air crew whether what the diseases they are having, the medical conditions or the cardiac conditions they are having. But here, since we know that this pilot is certified by the cardiologist that he is okay, fit for his duty, then I do fly.
Perfect. Sir, we will continue our discussion with my other attendees. Prashant, if I could have you unmute yourself, I will read your question and I will try to address that, but I want your opinion on this particular patient. So the question that you asked is, what if this patient has a TICFA? TICFA is a thin cap fibroatheroma and decides to create trouble mid-flight. So again, for non-cardiologists in the audience, thin cap fibroatheroma are one of the morphological features of coronary plaque, which are considered vulnerable, which are considered as the nidus on which acute coronary syndrome occurs. And the way we diagnose TICFA is by doing intravascular imaging, either in the form of IVUS or OCT. There are 2-3 issues with this question, Prashant. One is the way we diagnose TICFA is not yet standardized. That is one. And second, the correlation or the clinical outcome correlation of TICFA to coronary events, that also is not very well understood. And lastly, if you have a person who is being considered to be a pilot, and if there is lesion enough where you have to do intravascular imaging and define the plaque characteristic, this patient will be grounded, this person will be grounded. No matter what we do, how we explore and all this, airline regulations in that regard is pretty strict. If you have any coronary lesion which is 50% or more, in fact, certain guidelines would suggest even 30% or more, they will be grounded. Unless they pass a functional assessment and whatnot. So I don't think a person who has a diagnosed thin cap fibroatheroma will be your co-pilot. That will never happen. So the question of that person creating a trouble mid-flight and having an MI, that will not occur unless it is undiagnosed. A person with a vulnerable plaque is not going to be your pilot, that I can assure you. But I do want your impression about today's discussion. This case, 46-year-old male, right bundle, positive TMT, asymptomatic, normal coronaries 5 years ago. Would you clear him? Would you not clear him? Would you do some other investigations? And would you be comfortable taking a flight with him being your pilot? Prashant.
Yes, good evening, sir. This was just to stretch the discussion because I thought there was nothing else which was moving around, because all of them were the same questions. So definitely I would clear this patient who has a normal angio 5 years back and now probably a false positive TMT. And if this patient was a diabetic or a borderline diabetic, and if the normal, many times are, normal angio, but some cardiologists have the tendency to draw some plaques here and there. So if they were drawn by the previous cardiologist but reported them normal, then again this patient will need an OCT to clear him off, because if it is an airline, if they require a cardiologist stamp and everything, if they go very by rules and regulation, then maybe I will have to do an OCT. But usually all this first is not required. I will usually clear him, or if there is any doubt, then we can do a stress thallium for him or a CT angio. And yes, I'll be boarding this flight if this patient has been cleared by me. If I have seen him, then I have no problem in boarding the flight, sir.
Perfect. Thank you, Prashant. Anybody else has got any thoughts about this case before I move on with further information? If anyone has anything to share, you are welcome. I'm reading Srinivas sir's question. Is the cardiologist accountable if he or she has cleared after a positive TMT in case of an accident due to MI? Has anyone come across any such case till date? Sir, I don't know of anybody who has come across such, and if anybody in the audience knows, please feel free to share that information. What I can assure you is cardiologist does not have the accountability, because DGCA have got, or International Aviation, they have got very strict guidelines. Neither a cardiologist is allowed to deviate from that guideline, nor he will be held accountable if he or she follows that guideline and something happens. The problem will arise if the cardiologist goes out of the way, does not follow the existing guidelines, or overrides something which is contrary to the guidelines, and override saying that, no, in my opinion, this person is okay. And there, if something happens, then I'm sure that that cardiologist will be put onto the trial. But most of the time, to my understanding, that will not occur because airline will not accept it. Airlines are very, very strict in that regard, that things have to be followed in an absolute particular order. Now, having said that, lately we have heard about how airlines work. We recently heard a story where a pilot was tested positive on blood alcohol level on his way to flying, on his way to job, and he or she declared saying that I have been drinking for God knows how many years, I have never been tested. Lately, we also heard a story about one pilot who was flying on expired license for 20 years. We also heard last year or 2 years ago about a particular airline whom, when they audited, they found a certain certain percentage of their pilots did not meet the criteria of commercial pilot, but they were flying for so many years. So rules, regulations, guidelines, they're all there, but we all know that they are being flouted so many times, knowingly or unknowingly. As a cardiologist, I think we can put our recommendation, and then the airline makes their decisions based upon their protocol. Now, they may decide to ignore their protocol and just close their eyes and let the pilot fly. That is their decision. And I wouldn't be surprised if something like that does not happen. So, long answer to your simple question, and the short answer is no, I don't think cardiologist will be liable, provided he or she is following the DGCA guidelines. Okay, so any more thoughts about this particular case? Not what if, but this particular case. If not, then I will go forward with the discussion. So Praneeth, tell me, what did you order in this patient and what happened following that?
Yeah, so I ordered him a exercise tech, so where I can look at both anatomy and physiology, both in terms of his exercise as in stimulus for his stress and look for inducible ischemia. And he underwent that test and he reviewed with me with the reports.
Okay, and share with us what happened to that stress test and what was his calcium score and all those things.
So he came back with that SPECT image which showed an inducible ischemia in the distal LAD territory, and other segments were okay. And that was the report which was said, which again was not a full stop for me. It was a comma as a part of his evaluation. And as it was a comma, it had so essentially coronary artery needs to be evaluated based on this investigation, and I ordered him to undergo an angiogram again to kind of give him an authoritative clearance for his surgery. He underwent CT coronary angiogram after discussing with his team as well, and he reviewed with me with that report 2 days back. His CT coronary calcium score was 46.2, and his major epicardial coronary arteries were all normal, no issues.
Okay, so if I understand correctly, SPECT scan is positive for inducible ischemia and distal LAD territory. CT calcium score is 46, which is less than 100. And a CT coronary angiogram, which is, I'm guessing it's a high quality coronary angiogram, was negative for any major or minor epicardial coronary arteries. Is that correct, Pranit?
Yeah.
Was there any like moderate or mild disease anywhere, or was it completely normal?
Yeah, completely normal. Nowhere it was mentioned any mild or moderate. It was absolutely normal.
So I'm guessing this calcium score of 46 probably were just specks of calcium, probably adventitial calcium, because if calcium is present, there has to be some plaque. So yeah. I'm guessing some adventitial plaque or something maybe.
Right.
Okay. All right. So we did in the discussion, we had this question of doing further investigation. So we have further investigation, SPECT is positive, calcium score is kind of low risk, but it's not zero, and the CT angiography, which is normal. So let me get back to my attendees again and see what they would do. Srinivas sir, you have the information that you asked for. What do you do now?
Sorry, can you just brief me again, Dr. Anoop?
Yes, certainly. So this patient underwent a SPECT scan, exercise SPECT scan, I believe, with technetium, and that showed inducible ischemia in the distal LAD territory. CT calcium score was 46, following which a CT coronary angiogram was done, and that was reported normal. Normal means no major epicardial vessel stenosis with the small calcium score that you got. So now what do you do?
Right. I mean, it was all a distal LAD lesion.
No, there is no lesion. There is no lesion. It is just a SPECT which shows reversibility in the distal LAD.
And our CT coronary angiogram showed that there was nothing much.
Yes, CT coronary angiogram shows everything is okay with very minor coronary calcium.
And nor was there any anomalous course of the coronaries between pulmonary artery and aorta.
No.
In that case, I think we are quite comfortable, and we are quite comfortable in clearing him for his job. That makes our job easy, actually.
Perfect, perfect. Shankar sir, you got the information. Anything you can add to this?
This is beyond my purview. Okay, I cannot add anything, but since this MPI, that is myocardial perfusion scan, the SPECT scan shows a perfusion defect. The distal LAD and epicardial arteries are normal. So only strict surveillance I need. I ask him, because I told in the literature 1 in 4 men they will have a cardiac event at any time in the 5-year of period. So he should be under strict surveillance. Beyond this, I cannot add anything.
Prashant, you have some information. Anything that you can add? Would you clear him, not clear him? SPECT positive, CT normal.
Yes, sir. I would be more comfortable if he had undergone a conventional invasive angiogram. But since the negative predictive value of the CT, because it is absolutely normal, is good, so I'll go ahead and clear it.
Yes. So, to my understanding, and Praneeth, you can correct me if I'm wrong, he was advised an invasive coronary angiogram, but he's referring his command hospital, where all these airline pilots, they have a command hospital. They suggested to get a CT coronary angiogram, partly I believe because he already had a invasive angiogram done 5 years ago, and that was normal. So a CT was suggested this time, CT was done, and that was reported normal. Praneeth, is that the correct story?
Yes, Anoop.
Okay, all right. Okay, anybody else has got any other thoughts before we move on further discussion? Dr. Sandeep, we did not hear your thoughts in today's discussion. If I can have you unmute yourself and share your thoughts about today's discussion. Dr. Sandeep.
Good evening, Dr. Anoop and others. Um, I think appropriate line of management was taken. Only that, yes, even I do agree with the invasive angiogram. Why? Because for a distal vessel disease, because the perfusion imaging showed distal vessel disease. So yeah, I'm little skeptic about CT coronary angiogram. But again, since it's a departmental suggestion that the CT has to be undertaken, then agreed. But otherwise, I don't think I can add much to the discussion.
Perfect. Thank you so much, Dr. Sandeep. And while I will continue my thought process about today's discussion, if anybody has got any other thoughts, questions, or comments, please feel free to share. So Dr. Srinivas, sir, he puts in his comment that we should ask him to stop smoking. I think that is a very relevant thing to do, because smoking is an independent predictor of plaque rupture and coronary events. And remember, a pilot can get incapacitated not just by ACS, but even with stroke and whatnot. So quitting smoking is certainly a very good thing that this person should do. And we should emphasize, I really wouldn't want to be in a plane where a pilot smokes 1 pack of cigarette daily. That certainly is something that is not worthy of it. So 2 things that I want to add to today's discussion and the rationale why we chose this topic. Number 1, so airline accidents and airline events are probably one of the most studied events in the history of mankind. There is extensive research, there is extensive detailing that happens. And there are so many rules that airline industry has put on for us, which, while they are applicable directly to the airlines, we can also learn a bit from those rules. They are very stringent, but there are take-home points. So one rule that I want to share with you guys, and the rationale of why we wanted to discuss this topic, other than the fact that we should be aware of how pilots are cleared. So airline works on this rule of 1%. What that 1% means is, if you take all the events, medical events, which can make an airline crew incapacitated to do their job. In the current era, 100% of commercial airlines, they are manned by, or they're operated by multi-crew members for their pilot, for their in-flight service, for whatnot and all this. So they have got a multi-crew system, which means that if one member of the crew becomes incapacitated, then there is enough of redundancy built into the system up on 35,000 feet that the airline or the aircraft will still continue to function. So what their rule is, that if you select your crew member who has got an event rate of less than 1% per year, and the event rates, I'm counting those event rates which can lead them incapacitated, either cardiac or cerebrovascular or whatnot. If all the crew members have an expected event rate of less than 1%, and 0 we really cannot predict, but if they have expected event rate of less than 1%, then the true chance of the aircraft becoming incapacitated because of lack of crew is 1 in billion. And when I say 1 in billion or 1 in 1 crore, because there is very less chance that 2 or 3 key crew members doing the same job will get incapacitated at the same time if their event rate is less than 1%. So truly speaking, when we are evaluating these so-called high-risk profession, then we should ask ourselves 2 questions. Number 1, is he or she the sole operator of that particular machinery that we are talking about, in this case, an aircraft. If that person is the sole operator of that machinery, then 1% rule may not be applicable, because 1% rule means that if he or she operates that machinery 100 times, there is a chance that 1 out of 100 times he or she will become incapacitated. So that is question number 1 that we should be asking. Is he or she the sole operator of that particular machinery? And the number 2, are we reasonably certain that the clinical event rate to make that person incapacitated is less than 1%? And if it is less than 1%, then we should be reasonably certain. Now, in this particular case, the reason why I'm not very certain is because we know that if you have an abnormal functional SPECT, then no matter what is the epicardial arteries, they do have a higher event rate. Whether that higher event rate is still more than 1% or not, that I don't know. That for that to happen, this person has to be put onto a matrix of age-matched peer with smoking and risk factors and see where he fits into. But even with a normal epicardial coronary arteries, a person who has got a positive SPECT, and I'm hoping that SPECT was a high-quality SPECT, that puts him at a higher risk of event. I'm not that much worried about the TMT positivity. Why? Because of the reasons that Shankar sir mentioned. They have got a very high false positive result. But SPECT scan positivity is one of the strongest predictors of clinical event rate. So that is my idea about this case, number 1. Number 2 is, if airlines are working towards an event rate of less than 1%, and if we know their algorithm, if we know how they came up with identifying people who have got an event rate of less than 1%, and if we can modify those algorithms a little bit and put it in our own practice, then certainly we will also be able to evaluate people or patients who are not in airline industry, but with a modified algorithm in a similar fashion, and we can be equally confident that when we say this patient has got an event rate of less than 1%, that has been well tested, well validated algorithm, rather than what our gut feeling would say, or rather than what 1 or 2 research would say. Because these guidelines which have been created in an international aviation system, they have been created by very robust data and very significant clinical expertise. So those are the 2 takeaway points and the rationale why I wanted to discuss this case. One is to give you a concept of 1% that aviation follows, and B, that to a certain degree we should look at their algorithms, because there is science to it. There is science to it, and there is some understanding to it, knowing that they sometimes overdo these things. So I hope it kind of made a little bit of sense of what we were trying to discuss. What I did not include in today's discussion is what happens when a person already has a cardiac event, like a patient who already got an angioplasty done, or who had a heart attack, or who had a bypass surgery. Now what happens? Now how do you clear them to be your pilot? And that becomes a little bit more complicated discussion. So I did not put it in today's discussion, but if anybody has got any thoughts to share about that as well, I welcome them in today's discussion. Okay, so any questions, any thoughts, any concerns about today's case? Does anyone think we should still ask this patient for an invasive coronary angiogram? Praneeth, what did you do? Did you clear him, or did you insist on an invasive coronary angiogram for this?
No, I did not insist on invasive angiogram. I cleared him for his job as being fit to continue his job as a pilot. I advised him to quit smoking, and because his calcium score was high, I started him on statin, and I asked him to quit smoking and review after 6 months.
Now, do you know what happened when he went back to his so-called whatever command center, or whatever, there is a term for that? Do you know whether he was taken up for the job, or you think there is something else going on?
No, Anup, this happened only 2 days back, but I'll follow it up and get back.
Right, because if you have started him on statin, then to my understanding, he will be grounded. To my understanding, any cardioactive drug, if a person is taking, then that is assumed as if this person is at a higher risk of cardiac event than a normal person. And these people are typically grounded, at least for a year, if not two. So we would be very much interested in knowing what happened to this person when he went back to his command center.
Yeah, I'll get back to you on this.
Okay. Now, if he comes after 6 months or a year, what are you planning to do? You will do another stress test on him, or would you just do a clinical evaluation?
A regular clinical evaluation as to how is he doing and any new symptoms or anything. Nothing active investigation. A regular clinical evaluation.
Okay, thanks, Praneeth. If nobody has got any other comments to add, may I ask Somaraju sir for his opinion about this particular case and today's discussion that we are following?
Thank you, Anoop. It was a very interesting and useful discussion. I agree with most of you, what all you said, but I just want to add that take away all those things. If somebody is actively smoking, calcium score is not a reliable index of anything. For somebody who is actively smoking, the risk of his acute coronary event does not disappear from the time he stops smoking. It continues until 15 years. And they have to be on antiplatelets and also statins, etc. Then I won't get into the flight of an airplane where a pilot is smoking. Then the airline industry, the rules and all that, we'll come back to that later. So the second issue is if there is a family history of diabetes in this patient, the risks of smoking are even higher. So I'll insist on smoking. And if somebody is actively smoking, a normal angiogram today doesn't prevent them from having an acute MI tomorrow. Be aware of it. And then no risk factor evaluation helps in this subject. But having said that, again, being in healthcare industry, we are evaluating airline industry. Be aware that we learned the issues of safety in healthcare from airline industry originally. More than 15, 20 years ago, Institute of Medicine, it's called Academy of Medicine now, they came out with a document called To Err is Human. The number of patients who die in our tertiary care hospitals in US is more than 1 lakh. When they published it, everybody was upset and angry. And when they restudied, it was found to be even higher than that. And then we learned from airline industry for safety. You already quoted how airline industry is safer than even healthcare industry. So people in healthcare now are talking about safety issues, the airline industry. Congratulations for your, failing to forget where we stand in safety. And having said that, the word used, the sentence used in Institute of Medicine is the number of people who die of medical errors in our hospitals is like a big jumbo jet crashing daily. It doesn't happen in the industry, it happens in hospitals. Thank you. If he doesn't stop smoking, nothing else helps. And calcium score, angiography of any kind, stress test of any kind have no value. It will take 15 years for his system to become normal and the effect of smoking to completely disappear, for him to be called as if he never smoked. Thank you.
Sir, before I let you go, there are few questions I would ask you directly and get your impression. And I will not quote you, but I will directly ask your impression. If you were making guidelines for airline industry, would you say that a pilot who smokes should not be allowed to fly?
Yes. I would say yes.
And then second question is, what would be in your impression the best ischemia evaluation for an asymptomatic pilot other than your routine clinical history and physical?
See, if he is not an active smoker, all the things that all of you talked stands to reason. So any of those tests can be chosen, and but if he is smoking, none of those things can predict. I mean,
because the way I think is exercise or the TMT is such a, and I don't have a better word for this, that it's such a useless test in these kind of scenarios that I personally think that if I have to do a stress test on a person who is pursuing to be a pilot, if I have to do a stress test, then I would at least do a minimum of a stress spectrum or something like that, so that it gives some meaningful information rather than doing a TMT, because TMT or treadmill test is part of their protocol. It's part of aviation guideline protocol. I would think that if they would ask my consultation in terms of what should I put in, I would take TMT away completely, and I would replace all of that with a exercise SPECT scan. Do you think, sir, that is an overkill? Or you think we shouldn't be doing stress test at all?
I'll put it this way: if somebody is not a smoker, has no other serious risk factors, say calcium score and exercise, an exercise test which is negative, and if we achieved adequate exercise, is very useful. If it is positive, is not of great use in such a patient.
Perfect. Thank you so much, sir. We have 4 more minutes and we can discuss anything else in this regard. Anybody else has got any other thoughts, Srinivas, sir?
Yeah, and Dr. Anoop, the positivity of a TMT depends on whether the lesion is in the proximal LAD or the RCA, proximal RCA or LCX. For a single vessel disease, the positivity pickup rate is more for LAD as compared to RCA and LCX. So just because the TMT is negative doesn't mean the patient doesn't have any obstructive coronary artery disease. It is more positive if it is more proximal LAD lesion or a multivessel disease. So just because TMT is negative, we can't rule out a coronary issue.
Right, and I think that is where the pretest probability comes into play. That if you have a patient, like what Somraju sir was saying, if you have a patient who is a non-smoker and who has got no other obvious risk factors for coronary heart disease, if that person passes a treadmill test, it is more useful than a person who smokes or who has got risk factors for coronary heart disease. If he or she gets a normal treadmill test, that still may not be enough, as what you're saying, that because they may still have disease which did not get picked up on a treadmill. But if a person who otherwise has a very low risk, then a normal treadmill adds more value to the so-called normalcy. I still believe that a person who has got a pretest probability of less than 1% to begin with, a normal treadmill keeps it at less than 1%. Like it doesn't make it less than 0.1%, unless there is some data regarding it, which I don't know. But I would take that point. Low risk patient with a normal treadmill is a little bit more reassuring. Okay, other than pilots, Praneeth mentioned about crane operators. Crane operators are solo operators. So I believe they also have very stringent criteria, because if they become incapacitated with a heavy payload sitting, then it can be very dangerous. The other pilots, like locomotive pilots, train or ship and whatnot, they are also working at a multi-crew model. So there, I think that 1% rule is still applicable. Any other places I can't think of on my head? Yes, air traffic control. Air traffic control is very important there also. So if we get a person who works as an air traffic control, so although he or she is a ground support, but while being on the ground, he or she is managing airlines which are up on the air. So those people should also be followed with the same stringent criteria as pilots themselves. Shankar sir?
Even motor vehicle drivers also should be included in this high risk profession, because they also, especially the bus drivers, also should be taken into criteria regarding the same criteria should be followed to even these motor vehicle drivers carrying commercial.
So, Shankar sir, it's interesting you bring up the bus driver story. I agree with you that people who drive a public transport vehicle like a bus or whatnot, I think they should also be part of this stringent criteria. Although I would love to know what do we have in place in India. So if anybody who is interested, who has got some spare time, maybe if you can do a little bit of research online or offline, if you have any means, and share with us, are there any existing Indian guidelines or road transportation safety measures where the drivers have to follow a certain rules? Like, I have evaluated at least a few people who are pilots for a pre-job screening. But in my 4-year stint, I have not evaluated a single driver as a bus driver as a pre-job screening. I have treated them for their cardiac ailments, but I have not come across any bus driver who came to me saying that it is part of my job screening, so please do a health assessment to me. If anybody
Anoop,
yes sir.
I'll add, actually, for some time when we were at Nizam's Institute, we used to see many patients from this RTC. They don't have any system. They have no system at all. Then you realize many of them smoke, many of them have abdominal obesity, many of them have obstructive sleep apnea. So if you get into a bus in the night, be aware.
Yes, so that is a scary situation. And thank you for sharing that thought, because Praneeth, I remember you were mentioning a few months ago that when you were in your training, people who would go to these Amarnath Yatra and all these, they would come for a cardiac clearance. Can you elaborate a little bit on that?
Yeah, so while we are working in being a student in Usmania, it was a routine where they have these trips that every patient who goes to Amarnath Yatra need to get a clearance from a cardiologist and a kind of a government doctor. So we were there at that time. So they used to have the same profile of an ECG, echo, and treadmill, and based on which they were cleared for the fitness to go to that yatra.
So all of them had to undergo TMT, right?
Yes.
And what if they fail TMT? Then what would happen?
Then it's up to the discretion of the cardiologist, because in Usmania we do not have any other investigation like an X-ray stress or CT coronary angiogram. Either you have to do an invasive angiogram, which most of them do not agree. So either you have to clear them based on the clinical assessment of their physical activity, and most of the patients who can do, you do a treadmill, or else just clear based on ECG and echo.
Okay, thanks, Praneeth. Our today's discussion does bring up this whole gray area that we practice cardiology in, because even the pre-operative so-called risk assessment and whatnot, all of this is based upon our medical insight to predict what will be the event rate on this person if that person has to do this particular activity like Amarnath Yatra or driving a bus or piloting an aircraft. And this is not very what I would say objective, and I think a lot of this would be based upon our understanding of what the existing regulations or existing infrastructure or algorithm or whatnot is there. So as a practicing cardiologist, I think this is a very important armamentarium that we need to have, which we can apply to various of these aspects, like Amarnath Yatra or bus or a locomotive pilot or a crane operator, or some policeman who is going on a mission, or an army officer or whatnot. So some of these things, I think we need to have a basic insight of how to so-called risk predict these people as compared to a general population, where we are a little bit more liberal, because we know if that general population gets a problem, A, it's a problem only for them, and B, they can seek an immediate help as compared to these high-risk professions. So I think this is certainly an essential tool that every cardiologist should be well versed with. Okay, we are 8:05. Any last questions or comments about today's discussion? And I hope that 1% rule was helpful to our attendees. Maybe we can put it in perspective when we are seeing patients for some other random stuff, or even our routine life. The rule of 1%, where if the individual event rate is less than 1%, then the combined event rate goes down quite significantly. Okay, if nobody has got any other thoughts, then Praneeth, your closing comments for a few seconds, and then we will be done.
Yeah, so these are the cases which makes me uncomfortable, because at one end, if you are clearing them for surgery, you take the responsibility of his future events and other things, where it's a huge responsibility that you have to be really sure to clear him that he's fit for surgery. And at the other end, if you make him unfit because of any investigations, then am I the one who is responsible for making him lose his job? So a tricky situation, which I feel very uncomfortable dealing with these things. And that is where has been brought up to discussion to know how others feel as well. And the discussion was good enough, where the point which you highlighted about that 1% rule definitely helps in making decision process, greatest probability. And Dr. Somraju sir's highlighting about the importance of smoking, where all these rules will not apply when that one risk factor stays strong. So a good discussion, and many carry home points with this discussion that has come across. Thank you, Anoop.
Thank you, Praneeth. Thank you all of you for attending today's session. If any of today's attendee is not a part of our WhatsApp group, may I request you to join for any offline suggestion. I have shared the link in the chat box today. All the sessions are recorded, and they should be available on YouTube at some point, so you can go back and listen to our previous episodes as well. We are 66 now, and at some point we will run out of ideas. So this is a natural progression. So I request my attendees that please discuss with your friends, your colleagues, and think over if you have a topic, either directly cardiology or even outside of medicine, something that directly impacts us, that we should discuss. How to buy a car, how to do your taxes, whatever. Please share with us, and we will try to fit in one of the future huddle discussions. We are planning to have a commemorative book once we hit 100 episodes. And Dr. Praveen, who is not here today with us, has volunteered that he will help us compile the discussion that we had so far. I think this will be a very fantastic read for anybody of what cardiologists think and how do they make a decision, whatever they do. So thank you all for being with us for such a long journey. We will continue this for as long as we can. And we will see you next Wednesday with another topic. Till that time, if you can suggest us something, please do that. Good night, and have a good rest of the week. Thank you all.